Dr. James Laval is our next speaker. He's an educator, clinician, and industry consultant in the field of integrative healthcare. He is a licensed pharmacist, board-certified clinical nutritionist, doctor of naturopathic medicine, diplomat in homeopathic pharmacy and medicine with more than 20 years clinical practice experience in the field of natural and integrative therapeutics and functional metabolism. He's the author of 15 books, including Cracking the Metabolic Code. He is founder of the Laval Metabolic Institute in Cincinnati, Ohio, one of the first programs to incorporate natural therapeutics with a comprehensive interdisciplinary approach, including MDs, pharmacists, dietitians, acupuncturists, nurses, fitness, and other allied healthcare professionals. And I can say from being on his website, his CV is like 47 pages. It's worth a review there. We're very proud to welcome Dr. James Laval.
Told me that I have IBS, but yet someone else said that I'm just anxious and I'm having trouble sleeping and I'm pre-fibromyalgia, almost rheumatoid, maybe lupus, and I have chronic fatigue. I know you're going to be the person that fixes me. Right? I know you can help me, doctor. And it's a challenge now today because, I found, and I can't agree more about the food issue, and we'll talk about that later on. I have 3 dietitians on staff because everybody that goes through our clinic has to sit and talk with the dietitian and learn how to eat. Every person, or they don't come to our practice. Either have to learn how to eat, or I'm going to tell you, it's hard when you're, and now this is different than when you're prescribing meds. My docs will prescribe meds, and that's fine. But when you're talking about getting into an approach where you're inclusive of what foods are right for me, I'm going to begin to manage my stress. I'm going to begin to look at all these other issues that surround why I don't feel well. I'll tell you, I dodged that bullet a long time. I hand out handouts telling people how to eat better, and I'll give them a screening and hand out what they're sensitive to. But they have to functionally learn how to eat, and it's sad because people don't even know how to cook carrots now. Honestly, I've got my dietitian sometimes has to tell people how to clean a carrot, cut it up, and just add a little ginger to it when they cook it. And, it's simple things that people really, some of us that have grown up, my father was a very highly decorated chef. I'm very familiar with cooking, very comfortable in the kitchen. But a lot of folks aren't that way now. And so understanding that's important. So, you got to, right there. Guy, you didn't give me much room. See, I'm not a little person, so I'm going to be feeling really, now my cortisol level's up because I'm going to have to be talking like this. So what are we going to talk about today? What we're going to talk about today, and Sjogren's is just a model. It's interesting that finally in medicine, when you look at autoimmunity, there's finally this realization that, oh my gosh, the gut is involved. And Sjogren's just one of those models that I want to use that kind of catapults us into this whole aspect of autoimmunity occurs over time. You don't get diabetes overnight. You don't get heart disease overnight. 1 in 12 people in the country now are estimated to have an autoimmune disorder. 1 in 12. So this isn't going away, and I have to tell you, we can find nuclear warheads, like Enbrel, that we think is going to calm this issue down. But you know what? It's not. We know it's palliative. It works transiently. We've got to get deeper into why is it going on. So with Sjogren's, I picked it because a lot of times people come into the office and they exhibit some of the signs of it. It's a lot more common than people think. And it's something that is a real hallmark warning sign that there's some big problems stewing in the future. So obviously it's a chronic autoimmune disorder. White blood cells attack moisture-producing glands in the body. 9 out of 10 patients are women. Symptoms usually occur after the age 40, but either sex at any age can occur. Dry eyes, dry mouth, other symptoms, enlarged salivary glands, vaginal dryness, fatigue, fever, joint pain, swelling, dry skin, and rashes. Now, once again, people just aren't coming in presenting this. People are coming in saying, I'm not sleeping well at night. Well, as soon as someone tells me they're not sleeping well at night, I know that they've got elevated cortisol. I know they're in a pro-Th2 dominant immune stressor situation. I know they've got more thyroid binding globulin that's being released because of their sleep problem. So they're not just a patch of dry skin sitting in front of us for us to evaluate. They have all these other vectors that are kind of melting down on them all at one time. And it's important for us to kind of look at those vectors and go, all right, just as what was said, I think Dr. Ellithorpe was so right on about, you got to talk about what happened from the time they were born on. Because a lot of times we miss the pearls and we miss really what's happened to set up where they are today. And really, you guys can read the symptoms. We don't need to go through a list of symptoms. But, the basic issue is that we have this chronic inflammatory process that we end up labeling as Sjogren's. We end up progressing towards lupus. We end up, I had a case the other day, rheumatoid arthritis diagnosed with Sjogren's diagnosed. Well, wait a second. Are you Th1 dominant? Are you Th2 dominant? Which one are you? Well, the problem is, of course, is that there's hypervigilance in both directions. That becomes the issue, that it's a system that's on fire. Second most common autoimmune disease affecting 4 million Americans. When I first did this, I'll put this talk together, 4 million people with Sjogren's. You hear about that and you go, wow, it's, you hardly, I used to never see a patient come in talking about having, Sjogren's-like symptoms. 50% occur as a primary diagnosis. 50% occurs secondary to other autoimmune disorders, which makes sense. And 30 to 50% of rheumatoid arthritis patients, 30% of lupus patients, and about 4 to 5% of scleroderma patients have Sjogren's syndrome as well. Well, of course, because it's just a byproduct of an inflammatory process that's out of control. Here's the criteria, and for most of you, that's you're very familiar with going through criteria of what we need to look for if you're going to hang a diagnosis on someone. And often you'll see positive rheumatoid factor without any kind of rheumatic complaint. Enlarged parotid or salivary glands, it's also a factor. Other tests, Schirmer's test, tear production, salivary gland flow rate test, biopsy, the lip, measuring inflammation, urine test, blood test, rule out any kind of kidney, liver involvement. Other labs, obviously you can go through all sorts of labs. Even simple things like looking at differentials show you a lot of, early inflammatory signaling. I can't tell you how many times we see a white blood cell differential where it's, 13, 15, and people are going, wow, nobody mentioned that to me as a problem. What do you mean? My white blood cell count's fine, right? So, other conditions that are commonly associated, and this is where I want to get into when I put together this talk, is to understand that we have this ground swell of inflammatory response that's going on, and that these conditions are spilling out. And the more we see data coming out, I don't know how many of you saw the recent study, I think it was October of 07. I think it's an 8-fold increase in women with breast cancer that have autoimmune thyroiditis versus controls. Immune system that's out of balance. Now I have another comorbid, chemistry that's going on. So when we look, autoimmune thyroiditis, GERD. GERD, this is great, right? We'll just keep pumping in Protonics or keep pumping in the PPIs, and of course we'll thin some bone in the process, and we probably will knock out our B12 and our folate absorption, but that's okay. And this is chronically what's going on. Autoimmune thyroiditis, we screen it on everyone. It's so common. I think one of the biggest issues is when you get this sort of diagnosis, oh my gosh, you have antibodies for your thyroid. It's very common for us to find antibodies for the thyroid, and it's very common for us to turn those around and get them to go down. We'll kind of talk about strategies for how you do that. Raynaud's. You know, this is I went back one. Raynaud's, you know, occurs in 20% of Sjogren syndrome patients. Once again, another issue. When women come in and they have Raynaud's phenomena, you got to start thinking right away they're pre-autoimmune. There's a lot of women, you know, that are coming into your practices that are complaining, yeah, cold hands, cold feet, man, I open up the refrigeration section at the grocery store, my hands go white and they're in pain. That's an early warning indicator. Something's amiss. Gastrointestinal, abdominal pain, nausea, diarrhea. Well, of course, with 70% of the immune system in the gut and a lot of immune shifts occurring due to the gut, either due to whether you're talking about chronic antibiotic therapy. I mean, when I was growing up, I thought the pink stuff was something I had with each meal, and the purple stuff, which was Dimetap, was dessert. I mean, it was what I lived on the first 15 years of my life. It's no wonder that gut disruptions occur, and for all the rhetoric that we have about using less antibiotics in our children, it's still being done quite a bit. Quite a bit. So, obviously we have an underpinning of issues that are going on that is creating a whole body response that's driving symptoms. Obviously, and here, lack of PGE1, a factor, so prostaglandins that are low. Of course, in the PGE series versus the PGF series, when you have PGF2 series, it shows inflammatory chemistry that's going on. Here, there's no balancing prostaglandin effect. So, there's conventional medical treatment, and I don't really want to spend a lot of time on that because we don't have a lot of time together. I mean, what I really want to get into is what are some steps you can begin to do as you realize what's going on in the gut and what you begin to start to balance that, and not just the gut, but these subsequent issues that occur with it, the GERD, autoimmune thyroiditis, progression towards Th1 and Th2 dominated chemistries. It's that old story. People come into you all the time and they go, oh my gosh, I'm allergic to peanuts now. And everybody that's 50 years old or younger, grew up on Jif. The peanuts weren't killing you back then, and neither was, and I'm not saying that peanuts are great or the alpha toxin isn't an issue, but my point is that we develop these issues as we disrupt the gut. Everybody does, for example, as they look for these issues in the gut, they'll look at a blood anti-gliadin series. Well, the problem is if you don't have a 50% erosion of your villi in your gut, it's not going to show up in your blood. So it's understanding that there's a progression that takes place that you have to work at, and you have to work at really vigilance from the gut on up. I love this one. This one I always like because it's like, drink lots of fluids, use humidifiers. Well, I can get one of those portable humidifiers that I can hang around my neck, and I can stay nice and moisturized all the time, right? These are the things you read. Like if I pull up, hey, this is what we're gonna look at in the pharmacy literature, right? It's common stuff. It's good. It's fine. But the reality is, for most patients, things continue to progress. They simply continue to progress. They don't reset that immune point that allows them to regress symptoms and to actually feel better and more alive. So, what do we do in terms of a functional assessment? We always look at, an evaluation of symptoms, and that's a complete evaluation, meaning we really go through and interview, and I find a questionnaire works great. A lot of people go, oh, the questionnaires are so long. You know what? You can't ask enough questions in a half hour, right? So you give them stuff to fill out. You can review it while you're there. It spurs further conversation. But, in the end, what we try to get across to folks, and I think it's really just to kind of reiterate what was said earlier, when you think of it, what's going on is everything from the time, so, genetics is an issue, great. 75% of your genetics you control. You really do. We've got these gene SNPs. We've got to worry about MTHFR, and we've got to worry about KIF6, and we've got to worry about MOUSE because we might not get big enough ears if we don't have it, right? We got all these issues we're looking at genetically, but in the end, genetics is played out by what we do to ourselves and what the environment does to us. So there's genetics, there's diet. My mother was a hostess ho-ho's queen. I mean, she was, growing up in the 60s, if you weren't a hostess mom, you were a bad mom, right? I mean, I didn't get one ho-ho in my lunch. I got to take a box to school. My mother was going to make sure she was the hostess queen. So, so diet history is important. And I would challenge you that, everybody has the same diet. Yes, there's big things that you have to do in diet, but we have uniqueness. That's why you need to do allergy testing for foods. It's, and we'll get into that. But, so there's that piece. There's the evaluation of environmental load. What are you exposed to? What's influencing your enzyme substrates? There's the evaluation of what drugs are you on? One of the areas that I've written a lot on is the area of drug-induced nutrient depletion. And, it's interesting because you can track people with the drugs they're on and how their conditions are progressing. I'll give you a great example of this, and it's very important in terms of autoimmunity today because I really believe it's one of the major underpinnings of it, and it was mentioned in the earlier discussion. It's insulin resistance. People were becoming insulin resistant at earlier and earlier ages, and of course, insulin resistance begets, high LDLs, which begets a statin deficiency, because we're all deficient in statins, and that's why we need to get them in our diet. But the reality is this: as I'm progressing, and this is just an example of what happens and what triggers these autoimmune events in people. I'm a 25-year-old male. I'm told my lipids are elevated. I'm put on a statin. Fine. I'm not going to politically debate statins or not, and there's C-reactive protein lowering effects and all the other modifying effects, fine. Bottom line is, though, as we get on a statin, we're hyperlipidemic, which is a sign that we're already either low thyroid, high cortisol, something's up. And they stay on that for a year, then they come back to you and their blood pressure's starting to go up. And, of course, there's correlation to low CoQ10 status and poor regulation of blood pressure. Oh, my God, we've got to get you on hydrochlorothiazide. We're going to put you on a diuretic. And, of course, when you go get that diuretic filled at the pharmacy, they put a nice sticker on the bottle. It says, drink a nice big glass of orange juice, which is perfect for somebody who's insulin resistant, to drink a big glass of orange juice. So they get their potassium. But that really doesn't fit. Because what happens is it's depleting magnesium and zinc and sodium and CoQ10 at the same time, but they're only being given the sticker to get their potassium back. And, of course, magnesium is highly implicated in the development of insulin resistance and type 2 diabetes. So the next thing that happens is, you know what, your blood sugars are going up. I think we've got to add metformin. So then we're going to get that B6, B12, and folate depletion going on. It's going to elevate your homocysteine. And even though you're 31 years old and we're not checking homocysteine, 10 years of elevated homocysteine, what's that to your kidneys? You see, and then what happens is that progression or march towards, you see how easy it is to by age 30, somebody's on 3 meds. They're on meds that are depleting nutrients that are starting to trigger these base levels of autoimmune behavior, meaning, for me, insulin is the most inflammatory chemical in your body. And that's what's, as Dr. Ollithorpe had alluded to, that's the stuff that's going on. So now we got 8-year-olds that are going to be on statins, right? And we're going to start the process earlier. And so it's important in this evaluation that we look at, like I said, genetics, diet, environmental load. What's their drug history? If you have a woman who is on, I've had this. Women who are on oral contraceptives 15 years, they've not been on them for the last 5, but they have severely depleted folate pools because oral contraceptives do that, and they come up with colon cancer. Well, no, their recent history isn't, you have a folate deficiency due to the oral contraceptive you're on. But it's a misnomer to think that because a drug was given 5 years ago that it's no longer having a metabolic effect on that person sitting in front of you. So do a thorough, detailed history of drug therapy on people, both over the counter, because now people are taking H2 blockers and, as if it was candy, which is altering, the mechanics of digestion severely, right? You have to do a thorough drug evaluation of their whole life. What have you been taking your whole life? And then look at what nutrients are depleted. That's part of this evaluation for understanding how did I shift in my autoimmune behavior? How did I get here? The next, of course, from the gastrointestinal evaluation is really a full listing. What symptoms are you having? Are you doing any kind of fecal digestive analysis? What are you looking at there? Neuroendocrine immune support. I mean, for the most part, one of the biggest issues we find is that I can't get people out of central nervous system activation. When you look at 60% of the U.S. population is having trouble with hypervigilance now, right? They can't sleep at night. The majority of that's due to hyperarousal of the HPA axis. And if you look at the research, it's all about centralized cortisol and reductions in nighttime melatonin and, of course, all the sequelae that go with that. But this nervous system evaluation is important because people don't get that when they're stressed out, they're setting themselves up to become autoimmune. And see, people don't get that when they're insulin resistant. So one of the things we do in our gastrointestinal evaluation, part of it sounds like it would be silly to do that, but we do a 2-hour postprandial challenge. We make people eat a bagel and jelly at 6 a.m. and go in and get their insulin and glucose drawn. And all these people that are coming in with nice big stores of visceral fat, all of a sudden they're coming back with insulins of 150. And it should be about 15 to 20, right? And now you have evidence to go, you know what? This is part of your autoimmune picture. You see where your insulin is at? And why do you do a 2-hour postprandial? What's the definition of insulin resistance? Inappropriate release of insulin to a food load. But yet we look at fasting insulins as a way to dictate our insulin-resistant populations. And of course, if people have gluten intolerances, you give them rice and some jelly or something like that. So you can give them other things. Hormonal evaluations. And when I say hormonal, I mean right away people go, oh, BHRT, because I have one of my docs is a medical doc, OB-GYN's been doing BHRT. But you know what? We look at bioidentical hormones. Remember they're called secondary sex hormones? Because you have to look at cortisol and thyroid antibodies and insulin and glucose and really look at your primary drivers to your metabolism that are influencing hormonal vigilance. And yeah, of course, a lot more 50-year-old males have low testosterone driving their insulin resistance and plaquing process. Women with low progesterone and their myelin sheath is not being nurtured with progesterone, and so they can't sleep. We get all that. And you have to do those things. But you see, you've got to take a complete evaluation of their hormones to go with their gut. Now, in the end, I'm just going to tell you, I'm going to fast forward this. In the end, 25 years ago, I got into this business of really working with people's health. I remember reading a book by a guy, and he's an old-timer in this field, and some of you that are, have been in this a while may know, 'cause he's really more on the kind of the herbal side of the world, but it was Bernard Jensen. And I remember reading Bernard Jensen and him saying, you know what, death begins in the colon. He always reiterated, death begins in the colon, right? 25 years later, I'm up here talking to a group of docs going, death begins in the colon. You got to get the gut right. We got to get food antigenicity down. We've got to get IgG competency up. And I just want to make sure I reiterate that point as we move through this. That's the basis. You got to get to that. But you also, if I have someone with high cortisol, I can do a food avoidance program with someone. But if they're running 19 8 a.m. serum cortisols, or if you're using salivary cortisol and it's elevated, throughout the day, or it's low in the day and inverted at night, as long as their cortisol levels are high and they're pumping out a lot of histamine, their tight junction glycoproteins and the gaps in the gut are going to open up. And so if I don't evaluate that elevated hypervigilance and get them to calm down neurologically, well, you're going to be dealing with someone forever. Well, you know what? Here's your food list for this 6 months. You know what? These foods are great now, but now I'm reacting to this stuff over here. Because I ate this rice and I ate this quinoa and I ate this lamb because I wasn't eating lamb. You see, if I don't get the mechanics of neuroendocrine immune modulation, where I just look at it and go, okay, it's a whole person. I'm going to look at hormonal, neuronal, gastric, things outside of them. Where's their toxicity? What is their diet like? What is their history like? What is their drug history like? What nutrients are they depleted in? If they're low in zinc, good luck getting their gut to heal. It's not going to happen. Okay? So that's the point of our, of this whole talk, is begin to look at things. And this is kind of a way you could look at this. It's, here's where people are at. I'm under chronic stress. I have environmental load. I have an existing disease process or 2 or 3 or 4. Right? They come in and they got a list for you. They exercise or not. Maybe they overtrain. Right? How many people do you have come into you that maybe are kind of fitness freaks and end up in autoimmune processes because they've driven so much cortisol because of the amount of damage they do to their tissues due to their overtraining? Right? It's not just the people who don't exercise. We have people now who are into vigilant exercise in order to manage their stress. Prescription drugs, genetics, diet, all of these things. Just as I said, over time, it's how you're going to feel. So obviously, it's important for us to look at this whole aspect. And I'm going to go by this slide because I have a chart that kind of goes through this a little bit easier. And I know we don't have a lot of time, so I don't want to miss out on anything here. But let me take a look and see, like right here. So here's, you can really, this is simplified. But it's a way of looking at it in that people end up driving a dominance either on Th2 or Th1. But the reality is with this, when you look at this, is that, in general, people go, well, I thought rheumatoid arthritis was a Th1-driven autoimmune behavior. But how many times does your rheumatoid arthritis patients have severe IgG reactions to foods? Meaning that they can tell they have noted inflammatory response within 24 to 48 hours after eating a food. So now wait a second, that's Th2. So once again, the reality to this is that what's happening is both aspects of immunity are becoming hypervigilant. One's still dominating it. My natural killer cells are dominating it. But even in that end, what happens progressively to the rheumatoid arthritis patient over time? What happens to them as they get into their 60s? Are they good at fending off the flu because they're Th1 dominant? No, exactly. They're not good. They're terrible. They can't fend off the flu well. Their natural killer cell activities, is down. They become more and more disrupted. And I'll tell you, the biggest issue that you see in these autoimmune behaviors is you look at the drugs that are used. What's the drug of choice now to quell the fire? Big drug of choice. Enbrel is, it's kind of number 2. The first start off with prednisone, right? So they get hit with prednisone a lot of times. I remember starting off when I was first in pharmacy practice. I mean, we have prednisone in like 500 bottle counts to do prednisone. Now it's like, 55-gallon drums of prednisone. Right? I mean, everybody's on prednisone, I mean, it's an amazing thing. Point being is that to go back to this, why it's so important. If you had someone who had 15 years of prednisone history and now they're off of it and they're on a different set of drugs, well, prednisone depletes chromium and zinc. It depletes most B vitamins, vitamin C, selenium. It depletes zinc. Well, how can I mature a T killer cell if I don't have zinc? It depletes chromium. A lot of rheumatoid arthritis end up with insulin resistance and progression towards diabetes, which is another inflammatory signal. And I don't mean to try to sound confusing, but that's the patient sitting in front of you. They're sitting in front of you with this rich history and this milieu of immune response. And what I tend to try to get across is, what's a really good way to get started with folks? Is to get them to become less reactive. Remember the adult that, oh my God, I have a peanut allergy now. Or now I've been told I am gluten intolerant. It showed up in my blood, so now, once you get a positive on gliadin, you have got somebody with serious villus atrophy. Serious. And I can't tell you how many times people will come in and they'll say, oh yeah, man, I'm swelling and I'm gaining weight and I'm not sleeping well and I feel fuzzy after I eat. They're talking to you and they're moving back and forth and they've got nice dark rings under their eyes, and the more makeup that women try to put on, the more those dark rings show through. Right? Well, you've got to attack, and that's what I think what starts to happen is that, oh my God, the picture's so big, I got hormones to look at, I got neurons to look at, what am I going to do? One of the most important things you can do is get them, and as I said at the beginning of this talk, is you got to get them eating right. And when I say eating right, it's eating what's right for them. See, this thing of everybody's going to eat the ice cream and tuna fish diet and we're all going to feel good, or the cabbage soup diet, or how many things have people come into you and said, I'm eating the cabbage soup diet to lose weight, right? Or they're still on, I'm looking for a silver bullet. There are no silver bullets. And until you quell chronic immune signaling, firing this chronic, leukotriene and histaminic response, they're going to spiral downward. And we've got plenty of evidence. And one of the things that we have in our facility is we have imaging as well. And we've done brain imaging, contrast spec, looking at tagged, compounds to look at changes in things like glutamate and acetylcholine. Obviously, classic things for looking at plaque burden and MS. You can reverse that stuff. And you guys probably have seen it in your practice. It can be reversed. But my patient that comes in and they're my gluten intolerant person that has MS, but they still want to eat gluten twice or 3 times a month, and they're upset that they still are having visual disturbances. Well, maybe we have to look at the reward cascade for them, because maybe why they're reaching, instead of chiding them, right? They're in for the allergic response. It's giving them a buzz. We have to correct that neurologic terrain and understand that. So important to just see that from this standpoint, it was just noted. Eosinophilic esophagitis, how often? I've been in this a while, and I remember working, when I first got out of pharmacy school, I worked for the health department. I didn't have any infants in there with eosinophilic esophagitis. Think how common it is. 293 chemicals, I think, now. Is that the number? 293 chemicals in a newborn now that are foreign to them. And that doesn't count, a mother's low T3 expression, which affects the neuromedulla and medullary cortex folding that occurs in an infant, which is going to affect all of their receptor function for, central nervous system vigilance for cortisol. It's a tough task that we're at. So obviously, I'm a big fan. I measure TNF-alpha a lot. I find, TNF-alpha is one of those markers that's it's a research marker. You can grab it all the time, though. Typical labs will do it. And but the thing is what I find, even though you read this in the clinical literature a lot, most of the time TNF-alpha won't be high until someone is incredibly inflamed. And then you'll see it trigger. It's almost the same thing as fasting insulins in insulin-resistant folks. But I still measure this quite often, because it's an elegant marker that if it's up, you have got a forest fire on your hands, and you have got to do everything you can, because this progression is the progression towards ulcerative colitis, inflammatory damage to the kidneys, to the liver, to the brain, insulin resistance. TNF-alpha, for example, turns off your insulin receptors. So when TNF-alpha gets upregulated, which is a byproduct of cortisol elevations, TNF-alpha turns down your insulin receptor sensitivity. That's why chronic inflammatory processes due to stress end up putting, visceral fat on people, because you're turning off insulin receptor vigilance. The receptors aren't open anymore. They're not there. Now, once again, step back from it. The person that has elevated cortisol has a downregulated free T3 typically. And T3 is what causes insulin receptors also to be able to open up. So it's not the fact that, I'm just under stress that's causing my TNF-alpha to go up. It's the fact that I have this burst effect on my chemistry that's shifting me in all these different directions. So this is a way to look at this. For inflammation, from the standpoint of, I don't care whether you look at, autoimmune thyroiditis, I don't care if you look at MS, Sjogren's, lupus, you name it. The process is fairly centralized. Your body has smart bombs. It triggers inflammatory signaling early on. And so TNF-alpha, if you look at all the associated research, it is elevated and associated with C-reactive protein. It's elevated and associated with rheumatoid arthritis and Crohn's. It causes elevations in LPA, causes elevations in LDL, alters cortisol, causes sleep disturbances. So this is fairly well, I don't know how many of you've searched this quite a bit, but start doing, go out there and do some searches on TNF-alpha and find out how many thousands of hits are on it. But rarely are people explaining it to that patient. You know what? You're chronically on fire. It brings a new reason, it's a new meaning to saying you're hot, right? Oh man, yeah, I'm hot. Cool. No, this isn't a cool, you're hot. This is, you're on fire. And here's where you're going. It's the old James Brown. You got to get in the hot tub, right? I mean, you got to get out of that heat because it's a problem. It's a problem. You have to get this quelled, or what happens is you have these we read it all the time. You read dementia. Fourfold risk of dementia if you're a woman with significant visceral fat and insulin resistance by age 40. But you know what ends up happening is your patients come in. Here's how we do it. We do an infrared BMI on people. We tell them, you have 45 pounds of visceral fat. And then what I do is I walk out of the room and I bring in a model of belly fat, a 5-pound model of belly fat, and I jiggle it. I go, and I kind of drop it on the table in front of them. Can you believe you've got 9 of those? I would have never thought that. And then I take it and I press it up against their waist. Can you believe there's 9 of those on you? Here's the thing. And I have to tell you, what we're about is compliance. And see, and if you don't make a visual impact on someone, insulin resistance is going to lead you to diabetes and kidney disorders, and you're going to get on alcoholic fatty liver and blah. You know what? The patient's doing this on you. They're doing the meltdown, man. They don't get it. Bring in the 5-pound model of fat and tell them why their joints are aching and slap that model up against their belly and see how they listen. I'm going to guarantee you're going to see a compliance change. And it's okay to scare them a little bit. In a loving way. In a loving way, honestly. I mean, every person comes in, we take personal care, but you've got to get the message across. And once again, why I think it's so important is that when we look at chronic inflammatory signaling, this is one of the key things that disrupts the gut. Why do we have so much gastric issues with diabetics? Well, because with diabetes, you have elevated pro-inflammatory cytokines. IL-6, TNF-alpha are big. And this is, of course, elevated cortisol. And you guys, by now, I've been kind of writing about this now for a decade. We know these elevations in cortisol are big. One of the things I would challenge you on, though, is that there's some interesting new research. When you see low cortisols, we're all assuming that they're burned out. And there's some recent research from the areas of PTSD where it may be that the cortisol receptors are so sensitized in the CNS that you can only put out a little bit of cortisol because of the amount of vigilance in the receptor. It may not be pure adrenal burnout like what we've talked about and I've subscribed to for so long. I'm not saying, hey, this is something that really over the last 3 years, think of that person in a different way with those receptors. It's the old story of, we just have to, if cortisol's low, then we got to make it high. If it's high, we got to make it low. Well, yeah, you want to create balance, but you want to create balance in light of homeostasis integrity in the person. Just to jack them up. Oh, your progesterone's low, let me make it high. Your estradiol's low, let me make it high. Oh, we got to get your test up. Now, that's all good stuff, but within the confines of a complete guide of saying, you know what, I got to get you to balance out and harmonize, and your symptoms will guide that. Right? Symptoms guide that. Meaning, yeah, you know what, I'm not dropping at 3 o'clock anymore, doc. Well, your cortisol's still a little bit low, but at 3 o'clock you're saying you're okay. Well, maybe I don't have to push so hard with something to jack your cortisol up at 3 p.m. anymore. Maybe what I have to do is give your system time to reorient. So in light of this, just keep in mind, what's happening with all of these hormones is there's receptor signaling alterations that are occurring, and there's hypersensitivity, and there's hyposensitivity, and then you've got pesticides that are binding to these receptor sites as well. You got a lot going on. So go by their symptoms. How do you feel? Right? Yeah, measure some points too. We got to make sure their blood's looking good and they need numbers, and we've got to make sure we get things going in the right direction. But it's important that at the same time, how do you feel? Now, all of us worry about compliance. I've been in business 25 years. We will do somewhere between 150 and 200 patients a week in our practice, and all of them. If you want to make the term functional medicine, fine. I just call it we do good medicine. We have dietitians. We have I like the term interdisciplinary approach. It's an interdisciplinary approach, and the point being is you want to know the best compliance is results. Getting everybody to come in and convince them they have a vitamin in a fish oil. That sounds real good, but you know what? They leave your office, they take it for 30 days, they come back and they go, I don't feel any different, I can buy this at Sam's Club. I'm not going to talk about product quality differences and all that. I mean, now, granted, all those issues are there. My point is, you got to go after symptoms and make them feel better. So, inability to recognize foreign and self. Of course, we've got this issue of T cells and B cells, natural killer cells and T killer cells, wanting to go after, tissues. Lupus and Sjogren, T cells are present, B cells are dominant in the affected tissue, Th2 dominant. You look at rheumatoid arthritis, Th1 dominant. But remember, don't get fooled by, and when I read about natural products, I always worry about the fact that when people read, I'll give you a great example, don't use melatonin in an autoimmune disorder. Right? Do you ever read that? And I've written actually a couple of databases, for pharmacy on interactions. And here's what happens. Because melatonin improves immune function. That means it's an immune stimulant. When you look at pharmaceutical modeling, there's no, and when you're reading these, I'm telling you this this is probably the key thing. If you're going to get into using dietary supplements as a part of practice, you got to read between the lines a little bit, because for the most part, most of the interactions are theoretical. Most of the interactions are based on a pharmaceutical model, meaning that there's no modulation that's intact. So melatonin doesn't act as an immune stimulant, but by sleeping at night, your cortisol levels go down, you become less Th2 dominant, and your T killer cells come back to functioning. Oh, well, that's different than it being an immune stimulant. So just the reason I'm saying that is, you'll drive yourself crazy going, oh my gosh, I've got a person with lupus, fibromyalgia, diabetes, and polymyalgia rheumatica. What do I do? Oh my God, which part of the immune system am I going to work on first? Right? So we're going to get beyond that. For me, it starts there. I mean, it really does. You have to get to this aspect of how am I going to balance food intake? How am I going to create immune integrity in the gut? How am I going to limit dysbiosis? I mean, how many times, we've all got candida. There's a humongous fungus among us, and it's candida. And, look, candida is a commensal organism. It's there, and yes, it gets ticked off, and it gets overexposed when our immune system's out of balance, and it creates symptoms. But people don't have that sense when they come into you. They've probably been to several other folks, and I've been working on my candida for 10 years, and I have it back again. I'm fuzzy-headed again, and I'm bloating, and I'm not pooping good. Right? Right? They come back to you, and it's like, can you give me some more nystatin? Can you give me some diflucan? Blah, blah, blah. Oh, we're going to use something natural. Okay, give me more cat's claw. It's an allopathic approach. You have to look to, how am I going to reorganize gut integrity so I keep the organisms in check? And yes, there's real pathogens you have to look for, like the trips to Cancun, and missionaries in India and missionaries in Africa. And those are the folks you really have to worry about and be vigilant. But the bottom line is If you have somebody with chronic candida, you better start looking upstream real quick. Is it environmental load? Is it stress? Is it the rich history of antibiotics, oral contraceptives, NSAIDs, H2 blockers? All those things induce a flora that's ripe for a gut imbalance and subsequent immune disruptions and food allergies. I'm telling you right now, this food allergy, we haven't even touched it yet in terms of how it's going to impact people over the next decade because of the amount of use. What's the number 2 category of drugs right now? H2 blockers and PPIs. That's exactly right. Number 2 category is shutting down gastric acid. I wonder if that has an impact on organisms. And gee, I wonder if it has an impact on amino acid synthesis, and I wonder if it has an impact on inflammatory activity, right? Now, I'm not going to argue that if you've got Barrett's esophagitis and you got to knock down some inflammation transiently and heal something, fine. The drug was intended for a 9 to 12 week course of action. But when people were on them now for 5 years, and I have to tell you, I hope all of you are doing bone densities on your 55-year-old males at this point, especially ones that have been on PPIs for 3 to 5 years. This week alone, I've got 4 men with either osteopenia or osteoporosis. 2 out of 10 cases of osteoporosis now are men. Why? Because they can't absorb their nutrients. They can't build bone back. You got to get the gut right. They got hormone issues, right? They're not absorbing their minerals. But the point to this little kind of diagram is this. In the middle is my metabolic balance. It's my homeostasis. It's my process of how I end up feeling today. Everyone in the room, you're either well or you're on your way to being ill. There's no in between. There really isn't. I mean, if you're loaded with a bunch of environmental load and you haven't looked at it, it's one of those ugly heads that's going to rear itself in the future potentially. If you've been under dramatic stress for periods of time, same issue. So the point being is that this dynamic metabolic balance is essential to trying to think about how am I keeping someone moving through time and getting well and feeling better and feeling actually better than they have in years. It's pretty sad when our chemotherapy patients come to us because now we're bringing on a integrative oncologist to do nutrition workups for our folks because we've got so much work in that area in our city. In Cincinnati, we've got 4 times the national cancer average because there was a mistake of 100 million pounds of radioactive uranium dumped over 20 years. It mistakenly kept being dumped. Oh, did I press that button to vent that into the air again? Wow. So we've got these issues. The point being is it's pretty bad when people come in and get nutritional assessment and get their gut cleaned up and they come back to you while they're on carboplatin and while they're on Taxotere and they say, I've never felt better. Dr. Ellithorpe's back there going, yeah. And that's because you're giving them immune integrity, you're reducing systemic inflammation, they're absorbing their nutrients for the first time, and their outcomes are good. We've got a nice list of outcomes. So this is I've got the gut, the food I eat, the stress I'm under triggering chronic inflammation, the stress I'm under triggering intestinal tight junction, glycoprotein dysfunction, and then environmental load. So, detoxification evaluations, what can you do? There's a lot of things that you can do. Obviously, for us, we look at provoked urines on people, but if you are getting into heavy metal tests, the one thing I would ask you to do, replete people's minerals for a little bit of time before you provoke them. Meaning that if you've got someone who's been on hydrochlorothiazide for the last 15 years, and they walk into your office for the first time, and they've got peripheral artery disease, and they just did their arteries, and they're 63 years old by their plaque, but they're really only 47, so they're freaked out and they want to get cleaned out quick, right? If they've had a 20-year history of depleting that magnesium and you challenge them with a significant load to look at their heavy metals, remember, their magnesium status is going to get compromised too, as is their calcium, as is their other trace minerals, which could put you in a situation of things like atrial fib, arrhythmias. So just as a word of caution on provoked urines, and some of the other people may not be experiencing that, but over the last 15 years of doing that test, we saw that happen, and now we don't do that. We make sure we give people minerals for about 30 days, especially if they've got a rich drug history or if they have a requip deficiency. Right? If they come in and they have restless motor syndrome, it's a requip deficiency. It's not the fact that they have magnesium and iron and electrolyte issues. It's requip. Other things, you could look at fecal metal. You could look at packed red blood cell. You could look at hair analysis. We don't look at hair analysis all that often because we don't think it's a good marker for people, especially if they're poor detoxifiers, right? If they're poor detoxifiers, it doesn't show up in their hair. And so you would have to provoke them for 8 weeks and use the opening hair analysis as a nadir. And then after 8 weeks of provoking them, see what comes out. And that's if you're lucky. Because as we know, working in the autistic population, boy, it takes a long time to get that hair to pop. Or urine, or whatever, to show those metals coming out. Because they're such poor methylators. We do a lot of electrodermal screening. We think it's a great tool. Just a tool, not the end-all, be-all. Other things to look at detoxification, amino acid profiles, clearance challenges, organic acids. We'll do a lot of that, but glutathione pools. We do an oxidate, a redox potential on people. It's a great way to look at how poorly people are managing their inflammation is redox, right? So you can do a redox potential with a finger stick, capillary blood. You can look at redox, oxidation reduction capacity, and that's the rate of rusting in someone, right? Which is fairly correlated to chronic inflammatory disease processes, and degenerative disease is oxidative load or free radical load. Other types of infectious organisms, obviously, polymerase chain evaluations, fecal analysis, all these things. Intestinal integrity, and I know we've got about 10, 15 minutes or so. I want to make sure we get to it. This whole area of leaky gut, I still have trouble thinking why we think this is such a problem. Because, we're still in that, I teach at the College of Pharmacy and teach at the College of Medicine, and I still have trouble people thinking that, you mean the intestine, because there's not a big ulcer, that it's a problem? If it's not ulcerated? A great case in point. We had a woman in, actually the head dietitian at a hospital, pancolitis, getting ready to get her colon ripped out. Nothing's working, right? So we, in her situation, it was obvious. Lots of holes, lots of blood, lots of bowel movements, 20 to 30 a day. 2 months later now, she doesn't have the surgery. She's down to 1 to 2 bowel movements a day. Why? Because we understand that by eating the wrong foods, and because she's under the chronic stress of being the head of a department, and she tends towards being anxious as a Greek mother, right? And you guys saw My Greek Wedding, right? Is she a Greek? She's like worried about her son every day, She got some issues with those tight junctions. And she's triggering a lot of histamine, and she's triggering a lot of inflammatory response in the gut. We neutralize, she's better. So there's no doubt, and we don't necessarily, by us it's by default. We don't do a lot of lactulose mannitol challenges if you need to in order to prove it. Let's face it, if someone's bleeding when they have a bowel movement, or if they're complaining of irritable bowel, I have constipation with alternating diarrhea, or I have multiple loose stools a day. It's kind of like the old story of, let's see, it's wagging its tail, it chases after the stick, it answers to spot, right? You could put people through a bunch of functional tests like this. I think if you're going to do a functional test and convince them to do one, test them for foods. Because that way you can hand it out to them, say, look, this is what you're allergic, this is what your body's telling us you're allergic to. You got to get rid of these. If people understand that concept. But people get test weary. You talk about compliance, there's a big issue. Test weariness, right? Especially if it's all cash. My insurance isn't going to cover it. Obviously, these villi are so important, and bottom line is that as these erode and we eat foods that are high in lectin. Remember, wheat has 40% more lectins in it than the wheat that was grown 30 years ago. I wonder why we're having a problem with the lectins from wheat. You have a lot more antigenic load in the food. Not to mention the chemicals. And it's not just the lectins, right? It's the phenolic compounds that are in the foods that get across that gut-blood barrier and trigger this immune response that drives Th2 or Th1 vigilance, or both, with subsequent progression towards autoimmune disorders like Sjogren's, like, as all of you have done rheumatoid arthritis, and you put people on, rotation diets that are specific for them and clean up their gut. Oh my gosh, they don't need their methotrexate, right? So it's important that we think of these villi. As I look at this, I'm on a mission to save every villi structure that I can. I mean, it's that important. And when we don't, and why not? Remember when they started to do in irritable bowel or in colitis, and they started to look at doing punch biopsies to look for inflammation, but they weren't looking at TNF-alpha expression? Well, they were missing it, right? It's like we keep looking for that white blood cell. And oh my gosh, it's not the white blood cell that's going crazy in colitis. It's the TNF-alpha that's going crazy. So it's important to note that you've got to get to that point. And and obviously the integrity of this is so important. And what happens is that these tight glycoproteins, you guys are familiar with toll receptors, right? A toll receptor, what's it? It's kind of cool the way we name stuff. A toll receptor says, you're allowed through into the bloodstream, you're not. What guides toll receptors? What causes the expression of correct toll receptor signaling of nutrient absorption into the bloodstream? My functional medicine gurus in here, come on. Probiotics. The organisms in your gut have 100% control of those toll receptors. And so when the toll receptors are no longer able to function correctly, they do not have the signal to say, oh, you're not allowed in here. What starts happening? I start to create immunologic drive in the blood. Over time, more and more toll receptor disruption. I'm one of the best examples. Literally, when I talked about the pink and the purple stuff, I came from that generation. Double pneumonia at 4 months, 7 rounds of I became a pharmacist because I was at the pharmacy so much that I liked the pharmacist. That's why I picked it. You guys think I'm kidding. My mom worked at an independent pharmacy, the soda fountain, pharmacist back there compounding. And I teach for the compounding pharmacists quite a bit, actually, even today. But the point being is, when you have 7 to 10 rounds of antibiotics a year, and then 10 years of allergy shots, what's going to happen when you're 17 or 18? Other than being a little fuzzy-headed, right? But what's going to happen? As the gut erodes, and all of a sudden, and this is what you see, right? I can't figure it out after I eat, I'm passing out. Oh, you're hypoglycemic. No, it's not just that you're hypoglycemic. You're having a full immunologic reaction that's occurring because you have poor tight junction glycoprotein vigilance in the gut. You've got those glycoproteins between each of these cells, right? I've got glycoproteins that keep this intact. But as I create more immune response, what happens? The enzymes, the leukotrienes, the histamine, everything begins to erode those proteins. And so those tight junction glycoproteins become denatured. And that's how we become more alert. I mean, this thing of food allergies don't exist. I mean, we still hear people say food allergies don't exist. It's like, come on. Let's see. You eat that and you say it doesn't exist. Okay. So, integrity for autoimmunity of the gut is incredibly important. And here, and just to give you a good idea, you can look this up. It's very interesting. I know Department of Gastroenterology, University of Maryland, I think in 2005, had this great paper come out that just said, you know what? We do believe that autoimmunity begins in the gut. We do believe that this reaction, loss of integrity and hypervigilance that's driven. Now, I would say, yeah, it begins in the gut, but why? Is it environmental load? Is it stress? Is it drugs? Is it genetics plus drugs plus diet plus stress? What is it? Why is that occurring? So, we have to have these beneficial flora to influence tight junctions. We have to knock down antigenic load. We have to manage inflammatory chemistry, and we'll get to that now because I know I only got about 5 minutes. We already talked about having a gut on fire. let's just get to this whole piece of, we have to have some permeability, but we don't want excessive immune activation. We have to reduce microbe and toxin infiltration. And let's because we don't have a lot of time, let's get to some results. We already talked about this piece of chronic inflammatory signaling from insulin mediation and insulin resistance. Remember, make sure people get their mineral status up at all costs. You see, I'm a big believer in herbs, right? I think herbs are cool. I write a lot about them. I do studies on them. I look at extractions, all that stuff. But the reality is nobody has a ginkgo deficiency like no one has a requip deficiency. But see, essential vitamins, minerals, and essential amino acids and essential fatty acids are called essential for a reason. You got to get that right. But you know what? Even after you get that right, you have to re-regulate homeostasis, because many times those enzyme substrates aren't going to go back even with adequacy of those nutrients. So you have to be able to dampen it. So let's get to what you can do. This one I think is interesting because how important diet is. 15 years, those who ate fast food restaurants more than twice a week compared to less than once a week had gained an extra 10 pounds and a twofold greater increase in insulin resistance. Well, yeah. Plus, what are they eating? Lots of food additives and preservatives and things that tear the gut up over time. I keep thinking if we could do maybe a flaxseed immune globulin wrap that was edible when people pulled through. That way when they shove the food in their mouth before they get out onto the street, at least they'd have nutrients around their paper wrapper for the food, because they're eating the paper too, right? People are pulling out. They're trying to finish their food when they go through the drive-thru. It's like, I'm going to finish this before I hit the road because I'm answering my BlackBerry, driving, and I got to drink this coffee. I got to get that food in me, right? And so it's how fast can I eat it? And, of course, one of the biggest things, you want to get people to start to be less reactive. How about trying to teach them how to chew their food? You need something called salivary amylase to break your food down. So you can't get by on 3 chomps and a gulp, washing it down with a 2-liter. So what are some things that you can do? This is a raw material for sleep. Obviously, one of the things I like a lot, I use a lot of cat's claw in my practice because it has anti-inflammatory effects on the gut, as well as, and I like standardized, at least a 3% phenolic extract. You could also do TOA-free, but the reality is I just find cat's claw to be really good as an anti-inflammatory. It's gentle, very few reactions from people. My pancolitis case. Here's the things that I did with her. I used immune globulin powders. I used IgG immune globulin powders and fed her 2 tablespoons 4 times a day. It balances out immune globulin response in the gut, and there's some nice papers to support that. We don't have the time today to kind of go through all that. But I gave a lot of this. I fed her a bunch. In a week, she was down to 2 bowel movements a day from 20 and had no blood in her bowel. I used zinc carnosate. You guys using zinc carnosate? Zinc carnosate works just as good head-to-head in studies against PPIs. Works just as well. Obviously, you got to look for things like H. pylori and all that, but if you're not using zinc carnosate, you need to look up the studies on that and use that. Zinc carnosate, we gave her 100 milligrams of zinc, which meant there was probably about 370 milligrams of carnosate. It's about a 2/3 to 1 ratio. But the interesting thing on zinc is when they did a lactulose mannitol challenge on people and they gave them 200 milligrams of zinc a day for 30 days, 1 year out, their lactose mannitol challenge on the people that failed it, their gut was intact 12 months later. That's how important. You think of zinc on wound healing, think about inflammation and wounds in your gut, in your intestine. You need zinc to repair the process. So zinc carnosate for me, huge. These are 2 big ones along with get the bad bugs. If you want to use, I think we wrote nystatin for her because she had a nice big, once again, nobody asked anybody to stick their tongue out today. God forbid that we would actually have them stick their tongue out and see all the thrush. Right? So we looked at her tongue. It's geographic. It's cracked. It's big and plaqued white. So in her we used nystatin. And then we used about 200 billion cultures of probiotics per day. 200 billion instead of the typical 60 billion that you hear about. We loaded her up. Why? Because we got to get those toll receptors firing again. Now you can do a lot of other things, and I listed these down, but that was kind of one of the key things we did for that gut vigilance. And here's the thing. Inflammation went down. She also complained of joint aches. She complained of migraine headaches. All that went away as we repaired the gut and reduced the inflammatory signaling that was taking place. She was pretty much, 40 milligram a day prednisone person, on and off for the last 5 years controlling her colitis. Effective immune globulins on C-reactive protein. This is the use of immune globulin fractions that are from beef. And basically, we get a big reduction in C-reactive protein, which means when I balance that immune globulin response in the gut, I start to retard TNF-alpha expression and CRP expression. So, what do you need to do? I know I need to sum it up here, and my time is limited. You have to look at, you can do it a lot of ways. If you want to be palliative, give them immune globulins, give them probiotics, and deal with the unfriendly bugs that are in there. You can use high mucin sialic acid, right? High mucin sialic acid is a nutrient you can give them in 500 milligrams to 1,000 milligrams 3 times a day. It coats the villi so the lectins can't attach to it. So you don't get the white blood cell response on that villi. So high mucin sialic acid is something that you can utilize. It's very effective and has good papers, especially in Sjogren's. There's actually some papers where I've got that. Let me just show you this real quick so you guys know where that's at. And I know I got to get off here. High mucin sialic acid. Put a little star next to that one because in Sjogren's, there's good evidence for the use of that. Just remember 500 to 1,000 milligrams 3 times a day. And its purpose is to retard lectin adhesion to the villi so that you don't get immunologic drive or immunologic attack on the microvilli and get villus atrophy. We've got to protect those retarded, in a very loving way, villi. Let's see if we can get anything else in here. So here's the things we already talked about. In the long run, you got to look at heavy metals. You got to look at food intolerances and sensitivities right away. You've got to implement nutrition strategies for a new neuroendocrine immune homeostasis. Obviously, look at hormones and secondary sex hormones as needed. Address lifestyle factors. Believe it or not, you can't get by on 5 hours sleep a night, guys. And I was one of the best offenders in the world. I do not do that anymore. When you sleep 5 hours a night, you stimulate inflammatory cytokines. It's proven, it's shown in U.S. Department of Agriculture studies. 73% more likely to be obese if you sleep 5 hours a night versus 7. All right? So, boy, that went quick. So, thanks.